Welcome back. In part 2 of this lecture series, we shall take a closer look at outcome measures and discuss the characteristics of a good outcome measure. By the end of this section, you should be able to define what outcome measures are and explain the characteristics that make for a good outcome measure. So far, we have mentioned the term outcome measure on a number of occasions without clearly defining it. Let's take a closer look at what we mean by the term outcome measure. In healthcare, outcome measures are variables that reflect the impact of a disease and related healthcare interventions. While some outcome measures can be based on physiological manifestations, it is important also to consider what matters most to patients. Patient-centered outcomes measure how a patient feels, functions, or survives. In studies that evaluate interventions, outcome measures should be credible and robust and should be suitable to assess the potential benefits or risks of the intervention under study. Outcome measures can be primary or secondary. The primary outcome measure is the variable the investigator considers most important for evaluating the effect of an intervention. It is usually the measure that represents the greatest benefit of an intervention. It is used in the calculation of the sample size. Most clinical trials have one primary outcome measure, but some may have more than one, if there are different domains considered equally important to make a decision about risks or benefits. For instance, survival and quality of life. Investigators should decide on a primary outcome when designing the study, before it has started. Investigators are typically interested in several outcomes other than the primary outcome to gather additional information about the benefits and harms of an intervention. Secondary outcome measures provide information on other therapeutic effects that are also important but not considered as decisive in making decisions about whether an intervention works or not. They can include adverse events or other measures of benefit. For instance, in addition to survival or quality of life, an investigator conducting a trial in cancer patients may be interested in measuring fatigue as a secondary outcome. A trial may have several outcome measures. However, often studies are not powered to detect statistically significant differences in secondary outcomes. Therefore, negative results for these variables need to be interpreted with caution. As for primary outcomes, secondary outcome measures must be decided upon at the planning phase of the study. Composite outcomes are created by combining two or more variables together. For example, a primary outcome of major cardiovascular events comprises non-fatal myocardial infarction, stroke, or death from cardiovascular disease. Composite outcomes are most often used in situations where the frequency of the individual component events is rare. Using a composite outcome as a primary endpoint can increase the power of a study. Results from composite outcomes may be misleading. For instance, there may be opposite effects on different components. In a cardiovascular trial, one type of event may be reduced and the others not. It is therefore important to also report the results for the individual components separately. Let's examine the characteristics that make a measure a good candidate as an outcome for a clinical trial. For a measure to be a good outcome measure, it has to be valid or accurate, reliable or reproducible, discriminant, responsive, interpretable, feasible, and suitable to be used in a statistical analysis. We will now describe each characteristic in more detail. By validity, we refer to the ability of a variable to measure what it is really supposed to be measuring. There are various types of validity. Face validity is a simple and subjective way of simply examining at face value if a measure appears to measure what it purports to do. Different people, such as investigators, clinicians, or patients, may examine a measure to see if it relates to the domain of interest being evaluated. For instance, in an instrument designed to measure anxiety, the evaluators would determine at face value whether the items included describe states, behaviors, or feelings related to anxiety. Face validity is usually the first step in evaluating validity, but it's very superficial and only addresses a subjective assessment of what an instrument appears to measure. Criterion validity is a measure of how well a measure corresponds to an external standard criterion, or gold standard. Criterion validity can be assessed as concurrent and predictive validity. Concurrent validity is how well a measure compares with other measures currently known. For instance, an investigator developing a new scale to measure depression can compare the new scale to other instruments previously validated. As such, the investigator would administer both scales to patients at the same time and compare results. Predictive validity is how well an instrument compares with a future criterion measure. For instance, the investigator could assess how well the new depression scale correlates with future prescriptions of antidepressants. Content validity refers to the extent to which a measure incorporates all relevant aspects of the attribute under study. In a new scale to measure depression, in addition to being interested in the intensity of the affective dimension or symptom, we might be interested in the frequency of occurrence and impact on behaviors and function. Content validity can be evaluated by a panel of experts who can assess whether all important dimensions of the construct under study have been included, and can rate how important each one might be. Construct validity refers to the extent to which a measure conforms to all the underlying theoretical concepts. It's an overarching concept that encompasses the accumulation of evidence in the evaluation of a measure. Investigators may compare the new measure to other measures that theoretically should be associated with it. This is termed convergent validity. And also compare it to measures that should vary independently, termed discriminative validity. Another important aspect in the evaluation of construct validity is the assessment of how the various items included in a measure may relate to each other and whether they can be considered components of the same construct. Various statistical methods are used for this step, such as factor analysis or structural equation modeling. Item response theory has been increasingly used in the past few decades to assess validity. It is a more complex methodology that establishes the relationship between the individual items in an instrument and the latent attribute it measures. Another characteristic of a good outcome measure is reliability. Reliability refers to the degree to which results can be replicated under ideal conditions. A measure is reliable if it produces similar results under consistent conditions. Also referred to as reproducibility, reliability can be examined in different ways. Test-retest reliability refers to the degree to which results are consistent over time. Inter-rater reliability is the degree of agreement between different raters. Internal consistency reliability is a measure of inter-item correlation and indicates how well the items on a scale measure the same construct. This is commonly estimated by the Cronbach's alpha reliability coefficient. The next characteristic of a good outcome measure is discrimination. This is the ability of an outcome measure to distinguish between groups or populations of interest. For example, in a health survey, the ability to distinguish between healthy and non-healthy or various levels of pain, none, mild, moderate, or severe. Another characteristic that we expect a good outcome measure to have is responsiveness. This is the ability of a measure or instrument to detect change over time when it occurs. Reliability is very critical in responsiveness. Measures with poor reliability will make any real change difficult to detect. Another characteristic of a good outcome measure is that it should be measured on a scale suitable for statistical analysis. If our measure cannot be analyzed statistically, it may not be of much use to us. Examples of suitable measures are continuous variables, such as those measured on a visual analog scale, ordinal scales, which may be numerical, such as 0, 1, 2, and so on, or statements such as none, mild, moderate, severe. Finally, our measure could also be on a nominal scale, such as yes, no answers. Instruments that include various items may have equal weight for all of the items or may have more weight in some than others. If we give equal weight to all items, we assume that they contribute equally to our measure. That is, W is 1 for each component of the measure. For example, if we have a measure of symptom burden which includes pain, fatigue, and nausea, we could assume that pain, fatigue, and nausea all contribute equally. Sometimes we may assign different weights to our measure because we think our variables make unequal contributions to it. For example, we may conceptualize that pain could be worse than fatigue and assign a different weight to pain from that of fatigue. We may base weights on empirical evidence. If data shows that pain is worse than fatigue for the patients, more weight would be assigned to pain. Validation of a scale should include issues related to the weighing of the items. Let's take a hypothetical situation where we measure each of pain, anxiety, and fatigue on a scale of 0 to 100, with 0 being the worst and 100 being the best. We use the three measures to estimate the overall score. In the first instance, we assign equal weights to all the measures. Pain is scored at 50, anxiety is scored at 25, fatigue 75. We get an overall score of 50. Now let's assign different weights but the same scores. We assign a weight of 2 to pain, 1 to anxiety, and 2 to fatigue. We get an overall score of 55. In part 1, we saw that disease leads to abnormalities in biology, physiology, anatomy, function, or even vital status. These can manifest themselves in biomarker changes, symptoms, function, and so forth. Health is multidimensional and may be measured by looking for abnormalities in all its dimensions. We may start measuring health with vital status. Is the person dead or alive? We may measure health objectively by using surrogates for health. These may take the form of biochemical changes, such as measuring hemoglobin, physical, for instance, assessing the weight of a subject, physiologic, just as the use of EKG, or biological, just as the use of cell numbers, for instance, neutrophils, which can be indicative of an infection. There are also subjective ways of measuring health. They assess health status as perceived by the patient, the caregiver, the family, and occasionally the healthcare provider. This is the end of this section. We will now go for a short quiz.